Good afternoon, everyone, and welcome to today's webinar presentation, New Carbapenemase-producing Enterobacteriaceae Resources for Long-Term Care Homes. My name is Catherine Kerr, and I'm an IPAC specialist here at Public Health Ontario, and I have the pleasure of moderating today's session. To begin, I'll mention a few housekeeping items. To enhance the presentation experience, participant audio and video have been disabled. The chat pod has also been disabled to limit any distractions during the presentation. Please use the Q&A pod if you have any questions during the session. A discussion and question period will follow the presentation. And if at any point during the session you experience any technical issues, please email capacitybuilding@oahpp.ca. I would now like to introduce my co-moderator for today, Casey Gambetta.
Thank you, Catherine. I'm excited to be here to co-moderate this session with you today. It's my pleasure to introduce the speakers for today's session, Eva Skiba and Tiffany Chu. Eva joined PHO as an infection control consultant in 2009. She has a degree in nursing and also holds her gerontology nurse certification and certification in infection control designation. Eva is a member of IPAC Canada and was president of the IPAC Canada GTA chapter. Eva began her career in long-term care in the 1990s, where she acquired extensive experience in both as an infection control professional and a director of care. Eva also worked in IPAC in acute care at Credit Valley Hospital in 2009 prior to joining PHO. Eva has presented at national conferences and at provincial and local events. And we also have Tiffany Chu presenting today. Tiffany is an IPAC specialist with Public Health Ontario. Previously, Tiffany worked at as a public health inspector at several public health units across Ontario, focusing on infection prevention and control. Tiffany continues to maintain her certification in both infection control and public health, and bring her experience in infection control and public health to her current role with PHO. Please take it away, Tiffany and Eva.
Thank you, Casey. So just to echo what Catherine already mentioned, welcome to the PHO webinar to introduce the new Carbapenemase-producing Enterobacteriaceae resources for long-term care homes. For today's session, the objectives are, by the end of this event, you'll understand what Carbapenemase-producing Enterobacteriaceae are and why it's important to stop their spread. We'll also provide a high-level overview of the new CPE resources and what the resources are and how to find them. And finally, by the end of the event, you'll understand supports available from Public Health Ontario to start using the CPE resources. I did want to let you know, though we will go into a bit of background on what CPE is, really on introducing the 3 new resources and not an in-depth review of case and outbreak management. If you're interested in more education or a session on CPE in general, please provide that feedback to us during our evaluation. Before we get into the resources, I did want to provide a bit of background on what CPE is, why should we be concerned, and why it is important to stop their spread. So I'll start with some basic definitions. So we have Enterobacteriaceae, which is a family of bacteria found in the gastrointestinal tract. That's a common cause of both community-associated and healthcare-associated infections. CPEs are Enterobacteriaceae resistant to carbapenem antibiotics through the production of carbapenemase enzymes. And in almost all cases, these carbapenemase enzymes create resistance not only to carbapenems, but also first, second, and third generation cephalosporins and penicillins. They also frequently have additional mechanisms of resistance against other antibiotic classes, making the remaining treatment options both less effective and more toxic. So you probably noticed there are a lot of different acronyms related to CPEs that mean slightly different things, and I want to go over what the acronyms mean. So CRO is any organism resistant to carbapenems by any mechanism. So that includes carbapenemases, as well as increased expression of efflux systems and reduction of porin expression. CPO is any organism that produces a carbapenemase enzyme, including Enterobacteriaceae and others like Pseudomonas. And then CRE are Enterobacteriaceae that are resistant to carbapenems by any mechanism. This once again includes CPEs, but also includes other Enterobacteriaceae that are resistant by other means. So why are we focused on CPE when there's so many different other acronyms and organisms out there? It's because even though carbapenem resistance can occur in a number of ways, the rapid spread in Canada as well as across the world has been largely due to the enzymatic activity of CPE, and only CPEs have been designated a disease of public health significance requiring reporting here in Ontario. So a resident can be colonized or infected with CPE, and a resident who's colonized can also become infected. A quick review of definitions. Infection means that CPE is making a person sick and they have signs and symptoms of an infection. CPE can cause infections in any part of the body, but common infections include pneumonia, urinary tract infections, and bloodstream infections. Colonization, on the other hand, means that CPE is present on the body but does not make the person sick. And residents are most commonly colonized in the urine and in the gut. Colonized residents are the main reservoir for CPE, but CPE can also be found in environmental reservoirs such as sink and shower drains. And transmission can occur person to person through direct contact with infected or colonized individuals, or individually through contaminated surfaces or shared items and equipment. So before we can attempt to manage a case of CPE, we have to first be able to identify them. And exposure to CPE within healthcare facilities has been identified as the primary risk factor for infection, with increased length of stay and intensity of exposure, like having a roommate with CPE or a lot of contact with a resident with CPE. These are all contributing to increased risk. Recent travel and hospitalization are also important risk factors, but we're increasingly seeing cases that don't have this travel risk factor. So they're likely acquiring the infection domestically. It's important to ask residents about these risk factors on admission, and if a resident has a risk factor, they should be tested for CPE and start on preemptive contact precautions. This is referred to as risk factor-based screening, and the goal, once again, is to identify residents who are colonized or infected with CPE as early as possible in order to implement IPAC measures to reduce the risk of transmission. I want to highlight, though it's not as significant as some of the other risk factors, being a resident of a long-term care home in itself is considered a risk factor for CPE. So why are we concerned about CPE? First, the genetic information to produce the enzyme carbapenemase is often located on a mobile genetic element, and therefore CPE can share that gene that causes antibiotic resistance with other bacteria. Residents can remain colonized and potentially infectious to others for a long period of time, which is particularly concerning in a long-term care home and other group settings. There's also evidence that 16.5% of colonized individuals become infected, which is concerning because carbapenem antibiotics are usually used as last resorts to treat severe resistance. So but if a resident has infection with CPE, then treatment options are even further limited, leading to a higher mortality rate. And Canada has very limited options to treat CPE compared to the States, where newer antimicrobials are effective for CPE, have been FDA approved and are available. But these drugs, on the other hand, have not been marketed in Canada and have not been submitted for Health Canada approval, putting us at a much higher disadvantage and risk. So switching gears now, we're going to talk a little bit about the epidemiology of CPE in Ontario. So a total of 1,768 confirmed CPE cases reported in Ontario between May 1st, 2018 and December 31st, 2022. That corresponds to an overall incidence rate of 2.4 per 100,000 population. And for 2023, the rate of reported CPE cases is the highest it's been since data collection began in 2018. And there have been even more outbreaks reported than any other year and from more public health units than previously. And currently we have 4 confirmed CPE outbreaks ongoing right now in Ontario. So CPE is definitely a concern. Looking at cases by colonization versus infection status, a greater proportion of cases were identified as colonized with CPE at 46.2% than infected, which speaks to the importance of having those strong screening practices. An important note to make about this case status slide is case status isn't a mandatory field for reporting. And so data completeness was unfortunately affected by the pandemic, with case status being reported as unknown for approximately 40% of cases from 2020 to 2022. So it limits our ability to really discern any trends. Now we'll take a look at the current Public Health Ontario resources available on our website. So we have a couple of essential resources for CPE management housed on our dedicated CPE webpage. First is PHO's best practices document, routine practices, and additional precautions in all healthcare settings. And this PHO document you're probably already familiar with, but it is a resource important for management of CPE because in addition to sections on routine practices like hand hygiene and how to conduct a point of care risk assessment, the document outlines what is contact transmission, which is the mode of transmission for CPE, and it also covers the elements of contact precautions, including requirements for accommodation, signage, PPE, environmental cleaning, equipment dedication, and considerations for transport. The next resource is PHO's Annex A, which deals specifically with the screening, laboratory testing, and surveillance of a number of AROs, including CPE. And if you're looking for testing guidance or have questions on screening criteria, Annex A should really be your first resource that you turn to. We also have a number of standalone resources extracted from the two PHO documents and reformatted for ease of use. And this includes a table of clinical syndromes and conditions with the required level of precautions, an information sheet for patients, visitors, and healthcare staff that are applicable for all healthcare settings, and an FAQ on reporting requirements, and a sample risk factor-based admission form for screening. So that's a lot of resources. And with so many resources and a dedicated webpage for CPE, why did we create 3 more? So we created these new resources based on what we heard from stakeholders like yourself. So to start, an informal needs assessment was conducted by monitoring questions about CPE that were received in emails, calls, and at various education sessions. We also formed a CPE working group and brought together individuals from long-term care homes and public health units. And based on what we heard from the needs assessment and working group, we identified while PHO has a number of great CPE resources, IPAC leads felt that the resources did not recognize or address the intricacies faced by long-term care homes. And so I'll now let Eva review these resources that we've created.
Thank you, Tiffany. So as Tiffany mentioned, in response to the stakeholder needs, we have created 3 new resources for long-term care homes, and it was to help staff become more comfortable managing residents with CPE, of course, in line with the best practices, and also to promote greater confidence in staff's ability to balance IPAC with quality of life, because this is residents' home. So let's take a look at each resource now. So the first resource is an at a glance document on CPE transmission risk factors in long-term care homes. So when we formed a working group with representatives from long-term care homes as well as PHUs, we found a number of themes that IPAC leads described as being their biggest challenge or struggle when it comes to managing CPE in their home. Accurate and up-to-date risk assessment was one of the themes as well. And also IPAC leads felt that there was a lack of resources, mainly to guide decision-making processes in long-term care, and having more guidance that reflects the resident population and the physical limitations of facilities would be beneficial to closing this gap. And as many of you know or work in those older facilities where you still have the challenge of 4 bedrooms. And also from the quality of life perspective, it was evident that home-like atmosphere is hard to balance with resident safety. So we took that feedback and then created a resource that can be used by IPAC leads as well as staff to raise that awareness of risk factors for CPE transmission in order to increase confidence in making decisions around IPAC practices, such as placement decisions and involvement in social activities that would balance best practices with the quality of life. The tool focuses on risk factors that may be unique to long-term care home compared to acute care, and it includes, first of all, the design and infrastructure of the facility, the resident characteristics, and IPAC program characteristics. So Please note that this resource is for risk factors that affect transmission in a home when you do have a known case of CPE, and is not a risk factor screening tool to help identify residents who may have CPE. So the risk factor-based screening, as Tiffany mentioned, can be found in PHO Annex A document. So looking at this table, it's for physical design and infrastructure factors that would impact the risk of CPE transmission in your home. So oftentimes the greatest barrier or challenge when it comes to implementing IPAC best practices has to do with the physical infrastructure of the building, such as shared bathrooms and, for example, lack of private rooms, which of course is out of your control. So this table will allow you to assess the risk while recognizing the physical constraints that may be present in your home. So each factor is broken down into level of risk, as you can see in the table: low, medium, and high. So for example, looking at the factor of resident room, for example, there would be lower risk of CPE transmission if the resident has a single room. And then medium risk of CPE transmission if the resident had a single roommate, and then higher risk if resident had multiple roommates, and example would be like a ward style room. And while some of these key factors are also concerned in an acute care setting by addressing shared spaces and cognitive status of the resident, we are recognizing what makes the challenges in long-term care home unique when it comes to managing a resident with CPE. And we will walk you through the resources at the end of the presentation so you can see all of the tables. Right now, we're just showing some of the examples. So a neat thing about this resource is that it not only equips you with the knowledge of the risk factors, but it also addresses what to do with the information. So you can see a text in the green box. So there's a section ahead of each risk factor table that provides you with strategies to help reduce the risk. So in general, when the risk of CPE transmission is higher based on this fact sheet, the long-term care homes should be stricter with their IPAC practices. And this brings us to resource number 2, is a document on resident admission, discharge, and transfer considerations for CPE. So this resource was designed based on some of the struggles with CPE, as I mentioned, admission, discharge, and transfers. And it was produced to address concerns IPAC leads brought up around fear and also lack of confidence in accepting patients from acute care setting because they do not feel they have the knowledge, they don't have maybe the skills to manage CPE in their home. And of course, based on that feedback, we created a resident transition checklist that can be used by IPAC, by frontline staff, managers, in order to systematically assess preparedness and also identify and address gaps ahead of that transfer. So the resource consists of 3 checklists or sections. And each checklist has a spot to record the information for the resident, individual conducting the assessment, and the date so they can be completed independently of each other. So the first section of the checklist will help you determine what factors need to be in place prior to admission of a resident with CPE. And of course, the more of the factors you have in place or are able to implement, the lower the risk will be of spreading CPE at your home. So as an IPAC lead, you've done all this legwork. You share back with your staff the results of the checklist and also what you've done to address the gaps and what you have done to help prepare the home for the admission. So As a result, this may actually help alleviate the fear your staff may have and help build that confidence in their ability to care for and support the resident. So the objective of the second section, or the transfer checklist, is to facilitate an open communication between facilities, and also to ensure they have enough information to conduct their own risk assessment before the transfer, so they may prepare for a safe admission. And finally, the objective of the last section, or the checklist, is to verify supports that are in place to ensure residents and, of course, their families feel empowered to care for a loved one at home if the resident is being discharged home. This doesn't happen very often in long-term care homes, however, that checklist is in place. So the next resource, number 3, is a document with responses to common questions to support family members, visitors, and of course residents who are colonized or infected with CPE in long-term care homes. So the final challenge we've heard from our long-term care home stakeholders, when it comes to managing CPE, it's difficult in communicating effectively with families. So IPAC leads felt that there was a need to increase the level of understanding of what CPE is and its seriousness with family and visitors of CPE residents, and having more information to share that is, of course, easy to understand and would be beneficial to closing that gap. So once again, we took that feedback and created the frequently asked questions specifically to provide information on CPE for residents, family, and visitors. And I just wanted to highlight some of the key sections of this document, just to show you how the language and concerns are addressed in this FAQ directly relate to long-term care homes. So if you take a look at question 5, for example, what practices will the long-term care home put in place to prevent CPE from spreading to others? And there's some sample steps or answers that you might utilize to help you answering those questions. Another example, question number 6, how can I help to stop CPE from spreading to others? So again, there is bullet forms and answers and strategies to help you reply to those questions. So as part of this frequently asked questions, we also noted the PPE for CPE, which includes gown and gloves. So this is mentioned as part of the response to both question 5 and 6. But we really wanted to emphasize that gown and gloves are required when direct care is being provided. And we highlighted in the frequently asked questions. And it is important for visitors and family to participate in training on how to properly put on and take off the PPEs, since they will be wearing the PPEs when they're providing any kind of direct care, or they will be in contact with the resident environment. So this training should also include information on when PPE is warranted, and also incorporating the importance of hand hygiene as well. So here's some more examples of the questions. Question number 7, can a resident with CPE still participate in activities at the long-term care home? Because again, as we said, the quality of their life is absolutely essential. This is their home, so they should not be isolated, and they should still be able to participate in home activities. And question 8, how can I help if my loved one cannot understand or follow instructions? So we often see that on the dementia units as well. So we have these great 3 resources, and hopefully we were able to highlight what the resources are. and who they are intended for, and how they address the concerns specific to long-term care home when it comes to managing residents with CPE. And long-term care homes identify they prefer materials they can print and have them accessible or posted on the units. So the good news is all the resources have been developed in short printable formats, and those are available on the PHO website. So now I'm going to ask Tiffany to navigate the website so we can take a look at the website and see where to find these wonderful resources. Thank you, Tiffany.
Thank you, Eva. So this is our Public Health Ontario landing page. And if you go under diseases and conditions, and then healthcare associated infections, you'll find a number of different organisms. The first one is the one we are talking about, CPE, and it will take you to our dedicated CPE webpage. There are a number of great resources and surveillance reports available on the webpage. All the resources are listed on chronological order. So the three we're talking about here today are luckily on the top. So I'll go into each one to give you a quick look at what the resource looks like. So the first one is the frequently asked questions, information about CPE for long-term care homes, residents, family, and visitors. And once again, just to emphasize what Eva mentioned, it's really important to participate in training on how to properly put on and take off PPE, and that also includes when PPE is warranted for visitors and family. Then we have our risk factors in long-term care homes resource. The risk factors are listed in tables, and Eva went through physical design and infrastructure, but there is also a table for resident key factors, as well as one for IPAC program key factors. And finally, our last resource I want to highlight is the resident emission, discharge, and transfer considerations for CPE. It is consisting of 3 separate checklists, and they can all be completed independently of each other, depending on where you are in the process, because there's a section for assessor information, as well as resident information on each one. So you can just print off the 3rd page if you're in the process of transferring a resident with CPE. And once again, it has your standard radio buttons of yes, no. I did want to highlight about this resource is it does connect you to our other sources of information. So for example, under education has been provided to the resident and family as required on managing CPE at home and in the community, and the questions that have been addressed. If you're looking for additional information or supports on how you can go about doing this, there is a little subscript there that can direct you to our frequently asked questions. So just going back to the web page here, once again, there are a number of resources. If you filter by best practices, you can find Annex A, which again holds the information on testing and screening criteria. And then for this web page here, if you click on save, you'll be able to save this to your saved content once you have a MyPHO account, and it'll help you keep up to date and easily locate the resource. As mentioned earlier, this presentation is being recorded, and in a couple of weeks, if you're looking for the recording of the presentation, it would be under education events and then presentations, and you'll be able to find the recording of this presentation. So I'll just let Eva take over and we'll go back to our presentation.
So what are the next steps? Here at PHO, we are developing a number of resources, as you know, including risk factor-based screening tool. And the risk factor-based screening tool will be applicable to all healthcare settings. So acute care and also including long-term care homes. So later this month, a CPE surveillance report will be published online. So please let us know in the evaluation, or maybe send us an email if you could benefit from a more in-depth review of, for example, case definitions, maybe case management, outbreak management, testing, or maybe screening guidance for admission. And we also wanted to let you know that we did conduct a preliminary presentation that took place last week. It was very similar to this one, and that was with hub leads and public health units. And we asked similar questions. And we can continue to work with the hubs and health units to develop additional sessions, for example, working through practical case scenarios. So we have actually developed 4 case scenarios that might be helpful in applying the knowledge, and as I said, they're very practical. So I'm sure you will resonate with those, because they present the real life of long-term care homes. So please do let us know what you think about that as well. And for more information specifically about this presentation, please do contact us at ipackimplementation@oahpp.ca. And for any other IPAC inquiries, you can email us at ipac@oahpp.ca. And we've also included a link to our website as well. So this brings us to the last part of our presentation, which is questions and answers.
Wonderful. So thank you so much, Eva and Tiffany. And like Eva said, we will now move on to the question and answer segment of this event to address some of the audience's questions. A quick reminder to everyone to please continue to enter your questions into the Q&A pod if you haven't already had an opportunity to do so. We do see that several questions have come in about rates and things. So I just wonder if Casey, if you could just quickly comment on that before we move into the other questions.
Sure. Thanks, Catherine. Yes, so we will be coming out with some more recent data than that previous report that was mentioned in one of the questions. I think the plan is early in the new year to release the latest antimicrobial resistance in common hospital pathogens in Ontario survey results. So stay tuned for that information, and that's where you can go to find the most recent information on what's happening around screening and numbers. And I believe Tiffany and Eva already mentioned that there will be a new CP report coming out of Public Health Ontario that discusses CP cases from May 1st, 2018, when CP became reportable, until the end of 2022. So you can get a better sense of what exactly is happening in Ontario.
All right. Thanks, Casey. We've got some questions here, so thank you for the questions. The first question I'll ask is, are the precautions and disinfection practices the same as for other AROs?
I can take that, Catherine. So for CPE, the precautions is contact precautions, and resources or more information, contact precautions can be found in the PIDEP best practice document, routine practices and additional precautions. To mention about the environmental cleaning, so environmental cleaning is going to be important for AROs, including CPE, and some of the considerations you want to take into consideration for CPE cleaning is you want to ensure you're doing a daily routine clean disinfection. Routine healthcare grade disinfectants are sufficient to kill CPE, so you don't need anything special what you'd routinely have. And you should put thought into considering doing routine enhanced cleaning in sink and shower drains. As we mentioned, sink and shower drains are an environmental reservoir for CPE. I do want to mention that our environmental cleaning toolkit was updated earlier this year, maybe in September, and there is a great resource that maybe Catherine or Casey can throw into the chat. It's a frequently asked questions, significant organisms in environmental cleaning, and does go into detail about what different AROs are, including CPE, as well as the environmental cleaning considerations around each ARO.
All right, thank you. Okay, next question. Sorry, I'm gonna. Okay, so here's a question. This is a common one that comes up. And you know what, I can actually speak to this one as well. So there was actually a couple different questions in here about discontinuing precautions. So once an individual becomes positive, there's currently no guidance, at least in Ontario, through PHO on when this resident may eventually come out of precautions and when you can consider them clear of CPE. Eventually, the PHO guidance will be updated. PHO just has had many other focuses right now throughout the pandemic. And there are other documents that require some major changes. So CPE Annex A overall will eventually be updated. In the meantime, we have been recommending something somewhat similar to what you would do for your other AROs, just to be certain that they're not coming out of precautions when they may still be colonized with CPE. And so that would be typically waiting at least a few months before retesting. And then attempting to retest all positive sites. So that would include your typical sites. And then if there were also clinical sites, such as a wound that was swabbed, you would want to retest that unless it has healed. And to do that at least 3 times a week apart, making sure that that resident is not currently on antibiotics that could potentially impact the results. So if you have a situation like that, you're not certain, you can always reach out to us and we can provide some guidance on that as well. But that is typically what we are recommending, because we understand that residents in long-term care homes are in their home, and at some point we want to get them out of additional precautions. So that is currently what we're recommending, and hopefully eventually we will have actual written guidance for you. But if you're uncertain, please reach out to the IPAC at oahpp.ca email, and we can provide some guidance for you.
All right, thanks, Casey. We've got another question here I think is important. Is CPE screening mandatory or is it recommended in long-term care home settings in Ontario?
I can take that. So it's not mandatory. It is best practice. And typically healthcare settings are held to these best practices that are identified and indicated within PHO. So the PHO Annex A does apply to all healthcare settings, and it does indicate that, and highly recommend as a best practice, that there is admission screening for CPE upon admission to any healthcare setting. Right now, there's specific criteria in the PHO Annex A document that you can follow. I will note that eventually this criteria will expand to become more similar to what we are doing for MRSA and VRE, which is screening and testing anyone who comes from another healthcare facility who is admitted to another healthcare facility in Ontario, and not just internationally or outside of Canada. I believe that this was mentioned during the presentation, but in the new year, I can't give you specific dates, but at some point we are working on a resource, an MRSA VRE, CPE, and Candida auris screening tool that will be available for use, and that you can use for each new admission to actually go through a little checklist of what the screening questions are, identify if that new resident or new admission should be tested for CPE, and then provides just the quick next action. So what the testing is, what swabs you'll need. So stay tuned for that to help. Yes.
Sorry, and just to add, and I would highly recommend referring to one of the resources, which is the frequently asked questions. It's that document that already exists on our website is not specific to long-term care, but there's lots of really great information. And even though testing on admission is not mandatory, is based on risk factors. However, if your resident is positive for CPE, it is mandatory to report it to the public health unit.
Okay, thank you. We have another question. So do we test fresh new admissions for CPE or only ones who we know are already previously colonized with CPE?
And again, as we mentioned, it is a best practice, and it's also based on risk assessment, especially if the resident was hospitalized outside of Canada, or even if they were hospitalized in Canada in our local hospitals, and depends on the catchment area and the epidemiology of the area. If any of you ladies have anything else to add.
All right, we have a couple of questions about contacts in long-term care homes. So one of the questions is, if a roommate is identified, how often should they be screening the roommate for CPE? How early they can test for it? And then there was another question about when it's sent out to public health labs, it can take several weeks to get the results, which seems a bit unusual, but how that should be managed in the meantime when it takes quite a while to get the results.
I can take that. I can start. The question has disappeared, so hopefully I got all of it. But for sure, roommates should be screened for CPE. And similar to the risk factor based screening, you want to do it as soon as possible so that we can identify the case, especially if it's taking so long to get lab results back. But even pending lab results, if there are risk factors, for example, a roommate of a known case, you want to start instituting your contact precautions preemptively in order to prevent transmission as soon as possible.
And then just to follow up, Annex A has criteria for how far out you should be screening to ensure they have cleared it. So you can identify when the date of last exposure was, and then I believe it's 21 days after the last exposure is how far out you should be continuing to test the roommates to check for acquisition. There's a question here. It's, as a frontline worker in a hospital, we're seeing the long-term care homes overlook the CPE patients with results in extended stays. How can we advocate for our CPE patients in hospitals? I think what maybe you're asking is, long-term care homes may not have a private room accommodation or the capacity to take on that patient or resident, and so they end up in the hospital for longer. I think the first step is to reach out to your local public health unit, and they may be able to facilitate that conversation and looking at the risk factors for being able to get that patient out of the hospital and into their long-term care home where it's more appropriate for them.
Thanks, Catherine. And there is a bit of a follow-up question about the testing and whether or not to test while the resident is on antibiotics. So yeah, the idea is that if they're on antibiotics, that could potentially impact the CPE. If they're on antibiotics that are absolutely irrelevant and would have no impact on an Enterobacteriaceae or the organism of interest, yeah, that's typically not an issue. So it's more just make sure they're not on any sort of antibiotic that could have an impact on Enterobacteriaceae levels.
Okay, we have another question so there's a couple that kind of go together. So we have one just asking for clarification. Does contact precautions mean isolation? And then are residents who we know to be CB positive, are they allowed to join communal dining as well as other activities in the home, or should they remain isolated?
I can take that. So as I mentioned during my part of the presentation, it is so important to balance the risk factors as well as quality of life. This is their home, and the residents should be able to attend any kind of activities or communal dining. Just keeping in mind, doing that risk assessment is absolutely essential. And, every individual case can be different. You might have a resident who is very compliant with directions, with hand hygiene, with instructions, versus you might have a resident who is very disoriented and doesn't understand the directions. So ensuring proper hand hygiene, personal hygiene, teaching the resident about the CPE, about proper risk factors, and the residents who are unable to wash their own hands or clean their own hands, assisting them in that process as well, redirecting them, teaching families how to assist the residents, so making sure that the visitors and the family members are very aware. Some residents might have private sitters, so providing that instructions to the private sitter. So again, it will depend on each individual case. However, absolutely residents should be able to attend activities in your facility, participate in communal dining, and contact precautions does not mean isolation.
Thank you so much, Eva. We don't have any further questions in the Q&A pod, so I just want to put out a final call to see if there are any more questions. And it was mentioned previously, but just to highlight again, early in the new year, we should be releasing the ARO admission screening checklist that has the updated screening criteria for CPE to sort of match what we're seeing in the province. I know the PIDAC document is a little bit old, and so to keep an eye out for that, I believe Casey said it has the MRSA, VRE, CPE, as well as Candida auris. And I think that'll be really helpful for homes that already screen or are going to be implementing a screening program.
Thank you, Catherine. There are a couple more questions that popped in. So one said that if they have a first negative swab on a resident and then they start antibiotic therapy, do they need to restart, or can they do 2 more sets of swabs? And I think it's sufficient to do 2 more sets of swabs after the antibiotic therapy for confirmation. And it seems as if we are saying that in Ontario, we will be transitioning towards universal screening for CP, at least for anyone who has a contact with a healthcare facility within the last 12 months, or is in fact for absolutely every new admission, even if coming from home and have no contact with healthcare facility. No, so I don't see us going that way anytime soon. Who knows down the road? I can't speak to the future, but the idea would be more because you'll note when the new report comes out that there are a lot of new cases that do not have a international travel or healthcare admission as a risk factor. So we are seeing more and more transmission in Ontario. And so because of that, the idea would be to capture those who have had contact or admission to our own healthcare facilities and test those to make sure that they haven't picked something up in Ontario. So the idea of universally screening everybody, no matter whether they've had admission or healthcare contact or not. No, that wouldn't be the way we would go anytime soon. It would be more similar to what we currently do for other AROs like MRSA and VRE. Okay, and I don't see any more questions. Oh, there's a question about treatment. So we won't speak to treatment today. This is that's more of a clinical decision that would be made by the physician. So you can reach out, you can have a discussion with your physician if that ever pops up.
Okay, thanks everyone. As we wrap up today's webinar, I would like to thank Eva Skiba and Tiffany Chu for presenting and Casey Gambetta for co-moderating with me. I would also like to thank everyone who joined us for today's PHO webinar. You can expect to receive a brief anonymous survey for today's session. Please try to complete this to help us improve our programming. A reminder to everyone that TOPIC, or the Ontario Public Health Convention, will be held March 26th and April 23rd in 2024. Registration opens on December 15th, and you can check out tophc.ca for details. And lastly, to access past presentations and view confirmed upcoming sessions, please visit the PHO website, head to Education and Events, and then click on Presentations. Thanks everyone and have a wonderful day.